turn on the microphone. I always forget to turn on the microphone when I first start the stream. G'day everyone, Jamie Chapman here for It's All Happening at UTAS. Normally I'm joined by Dr. James Crane, but unfortunately today he's unwell. So he was going to handle most of the physiology side, so unfortunately we're going to be focusing a lot of the anatomy that happened today for this week anyway for the practical, so we can reinforce some of that content. And we can have a quick chat about some of the physiology towards the end if we get time. Otherwise we'll sort of leave the physiology questions a little bit more towards a future stream, maybe next week, if that's okay. Chanel, hello and welcome to everyone who's here so far. So I can see Gamer Ethan's here, Noob Wedge, and Chanel's here. Chanel's already jumping on, ready for a question. I hope it's anatomy related, otherwise we may have to defer the question till a little bit later, Chanel, but go for it. I'd like to know more information about compliance in cases of emphysema, please, and also how it increases compliance. Okay, so as I said, we're gonna maybe leave some of the physiological sides of compliance to another stream because we don't have our resident physiologist here. But compliance, of course, is all about elasticity, and so we can talk about the anatomy in respect to compliance, and we can definitely talk about emphysema and how that affects compliance through the reduction of elastic fibers within the lungs, which reduces compliance. Okay, so what we're going to do is talk about the anatomy of the respiratory system. Of course, we know that the respiratory system is sort of divided into two components. It's divided into the conducting portion. So we've got the conducting portion, and then we have the respiratory portion. Okay, so what can we consider as part of the conducting portion of the respiratory tract? What's the sort of first parts of the conducting portion? I know I put a lot of questions out to you guys, and it weighs on you guys. So yeah, the nose down, that's right. So we've got the nasal cavity. We have, of course, the pharynx. Here we could probably fit in as well the oral cavity for the mouth breathers in the room, me, myself included. Yeah, that's not how you spell pharynx. Yeah, that's just terrible. So don't listen to me. We've gone. You see, I'm not a multitasker. So pharynx. That's ridiculous, isn't it? All right, and we can actually divide the pharynx into three regions. We can divide it into the nasopharynx. We can divide it into the oropharynx. And we can divide it into the laryngopharynx. From the pharynx, we then move to, of course, the larynx. Then into the trachea. Bronchi. I've got the dot. Come on, dot. Bronchioles. Okay. Does anyone know the sort of the point at which the conducting portion of the respiratory system sort of stops? So it's one of these bronchioles. I'm not sure if you covered it in the lectures, but there's a part of the bronchioles where the conducting portion ends, and then we move into a dual sort of role for both the bronchiole that has both a respiratory function as well as a conducting function. Does anyone know the name of the last part of the conducting portion? No? Okay. So the last of the portions of the conducting portion is a region known as a terminal bronchiole. And so this is the last of the conducting portions of the respiratory tract. Then we move into the respiratory zone, and from here, the first of the respiratory zone is known as the respiratory bronchiole. So this respiratory bronchiole actually has a dual function. So it has a conducting function, so it brings the air to the where the respiration is going to take place, but it also has these little out pockets of alveoli as well. So it actually can perform respiration, gas exchange, but it also is a conducting portion. So from the respiratory bronchiole, we then move into the alveolar duct, which then moves into the alveolar sac, and then into the alveolus itself. So these are the sort of the breakdown, I suppose, of the respiratory tract in terms of the parts which are just purely bringing the air down. Now we say purely bringing the air down because we know that it's not their only role. They also, of course, play an important role in modifying the air that's brought in. So that can we sort of call it sort of air conditioning, I suppose, not sort of like the AC that you have in your car or your house, but it actually conditions the air in preparation for it actually reaching the respiratory zone so that efficient gas exchange can occur. So that sort of air conduction, or the processing of air that takes place, involves warming, it involves filtering, and it also involves humidifying. So that the air is warmed, it's cleaned up before it reaches the alveoli, and it has water added to it. Because the air is generally quite dry. Unless you live in very humid environments, it can be relatively dry, and you want to add some water to it, some water vapor to it, so it actually doesn't dry out all of these lower respiratory systems. All right, so we're going to sort of anatomically make our way through. We're going to be looking at different components of these as we make our way down, eventually leading to the alveolus, of course, and the alveolus is where we find, well, all of these actually contain examples of it, but where we find the respiratory membrane. And so we'll be talking about the structure of the respiratory membrane. It's also sometimes known as the air-blood barrier. I don't know if you've seen that term before, the air-blood barrier. What structures in the upper respiratory tract filter air? Well, Noob, we're going to actually talk about that as we make our way through. A lot of the filtering actually happens in the nasal cavity. So if you're a mouth breather, some of the filtering process is actually taken away. The hairs within our nostrils actually play a really important role in filtering the particles, the larger particles from the air, and preventing them from getting lower down. But then once we actually get down to these lower regions, we do have other components which play a role in that filtering, and we will talk about that. Okay. So I'm just going to quickly save that there so we can have a look at that at another time. Okay, so that's the picture there. Let me get rid of that. Okay, so clear that. So we're going to start off by having a look at the nasal cavity. Now I'm going to apologize for my drawing. I'm not the best artist in the world, so we're probably going to be overemphasizing various things. This person is going to have quite a large nose. Okay, so we get a bit of an idea about this person here, okay? So here's their nose. Who remembers what the little opening to the nostril is called? The anatomical name for it. Starts with N? Nares, good, well done. Welcome along, Sri Lankan man. So it's the nair. Well, there's two. There's nares, but the singular, of course, is a single nair. Gamer Ethan, thank you very much for the follow. I really appreciate that. So this, of course, is the outer part of Sri Lankan man. Thank you very much for the follow. Appreciate that very much. We can divide the nose, I suppose, into two regions. Anatomically, I kind of divide them into three, but two regions is fine. The outer part here, who knows what the outer part of the nostril is called? starts with V. You might have it at the entry of a building. It's known as the vestibule. And these are actually, if we think about them together, these are both made up of skin. And it's made up of hairy skin. So the hairs in this region are known by a name which you probably more closely associate with other mammals. These are vibrissae. So vibrissae are the sort of little feelers that we see, typically associate with cats and mice and rats and things, as a way to detect things. Now in humans, vibrissae, or the nasal hairs, play an important role in the filtering. So some of the larger particles are actually filtered out by the nasal hairs. Anything that's sort of smaller than a certain size actually then gets into the respiratory tract. And then we have other mechanisms that we can use to actually get rid of those particles, which we'll talk about in a little while. Now, anatomically, we sort of have these, the nasal bone in the middle, and the nasal bone is thrown into these three folds here in the nasal cavity. So let's say we imagine the sort of posterior region of the nasal cavity is here, and then we have these three folds. And they're bony projections. They're actually made up of bone, and they're lined by respiratory epithelium, because once we sort of reach this zone here, most of this is actually lined by respiratory epithelium. Okay, and respiratory epithelium is a specialized type of epithelium. For those of you who did CZZ 101 with me, you may remember the epithelial type pseudostratified ciliated columnar with goblet cells. Now that's a bit of a mouthful, a bit of a long name, but basically it means it's a simple epithelium that looks like it's stratified. It's ciliated, it's got cilia on the surface, and it has goblet cells within it. And the goblet cells help to produce a mucus, which is one of the ways we actually trap and filter the air that's coming in. So filtration is done by the vibrissae, but it's also done by the mucus that's secreted as well. Oops. And that comes from goblet cells as well as underlying seromucus glands within the mucosa of this lining. Now these projections, which sort of project outwards into the nasal cavity, have names, and their role is to actually slow the air down within the nasal cavity so that the air gets more time to interact with the epithelial and mucosal lining within the nasal cavity, and that helps that filtering process. Yes, Sam, welcome along. Yes, conchi is exactly the name for those. They're also known as turbinates because they turbulate the air, slow it down. And so they're named depending on their location. So we have a superior, we have a middle, and we have an inferior conchus. Conchi is the plural, conchus is the singular form. Now they actually have then these little spaces within them. So when you breathe air, those spaces, the air travels through those spaces. And those spaces are referred to as meatus. So we have a superior meatus, a middle meatus, and an inferior meatus. And so the role of the conchi, as I said, is to increase surface area for having the respiratory epithelium here, so, and also slowing down the air so the air gets time to actually undergo all of this filtering process that takes place. So we actually have within the epithelial lining here, we actually have a number of thin-walled venules, and they're responsible for actually warming the air. We also have some seromucus glands which produce a thin watery fluid which helps to humidify the air, and then the filtering is performed by, after it passes the vibrissae of the nasal, the vestibule of the nasal cavity, the mucus. So the goblet cells within the epithelium as well as seromucus glands produce this mucus which helps to trap particles in this region, and then the cilia help to move them along into the oral cavity for swallowing. So we'll see that process of that trapping of particles from this respiratory epithelium all the way down. Now I've got this slide here. What we're looking at here, I might sort of zoom out a little bit if I can. Let me get rid of this. So this is a section of the head of a fetus. So this is the brain up here. We've got two eyes. This is the nasal cavity. And this is the oral cavity. So we've got a tongue here. So this is the oral cavity. We've got the jaw developing. So we're obviously going to be focusing on this structure here, which of course is the nasal cavity. Whoa, I apologize if you get seasick. So if we have a look at this then, let me just change the color of the text here. So here we have cartilage. So this is all developing still. So this is still this will eventually become our nasal bone. And then here we have our projections. So we sort of get these projections here. This is the superior concus. This is the middle concus. And then this is the inferior concus. And so then these are the meatus that I was talking about. So we have the superior meatus, the middle meatus, and then the inferior meatus here. And so we can zoom in here. We can sort of zoom in. We've got to get rid of this first, of course. And so here's our respiratory epithelium, okay? So this is that pseudostratified ciliated column. You can see all the cilia here. So these are the cilia. Now this is developing, so the goblet cells aren't very present, or certainly not very visible in this section, but this is the respiratory epithelium. And then if you remember, we were talking about the sort of respiratory epithelium. Then in the superior most part of this epithelium, we actually have another type of, or another region of the nasal cavity, and that is the olfactory region. Okay, so the olfactory epithelium forms a very small region actually in humans. Humans have very poor sense of smell, and so the olfactory region is actually quite small in the superior part of the nasal cavity. Now, if this was a dog, and you know dogs have those longer snouts, most of that superior surface is all that lining of that olfactory epithelium, so dogs obviously have a much greater sense of smell than humans do. That's probably a good thing, knowing how smelly we are as humans. I can't imagine living with my teenage sons. They smell bad enough now. I can't imagine what it'd be like if my olfactory epithelium was much larger than it currently is. No offense, boys, if you're watching this stream. So the olfactory epithelium contains bipolar neurons, olfactory neurons, which sense the smell, and then those neurons run back into the brain, where it interacts with the olfactory bulbs, which are part of the olfactory nerves, which of course is one of the cranial nerves of the brain. Now if we go back to the this slide here, we can actually see that. So if we sort of zoom out a little bit, these structures here, these are actually the olfactory bulbs. So this region here would be the olfactory epithelium, and the nerves of this epithelium would be running up and making contact with cells here. So they're relaying that olfaction, the smells, the sense of smell, up to the brain here, and then the brain processes that information. So here we actually have the bone, which is developing, known as the ethmoid bone, which is the sort of superior part. And the nerves, you can actually see some of these nerves here, of the olfactory nerves. So these are actually nerves, and they're running up, and there's actually little holes within this developing bone. This region is known as the cribriform plate. There's little holes here in this ethmoid bone. The nerves run through and then make contact with this region here, and then deliver that sense of smell. So you can see here we've got this cartilage. This is cartilage here. So this is going to form the bony core of the superior concus, then the middle concus, and then this inferior concus. So you can actually see that the bone will eventually develop here. We can see some of this newly forming bone here, and then this cartilage will change into bone. Okay. Right. So then obviously, any questions about the nasal cavity before we sort of move on? Let me change back to the black color. Okay, so then we move, obviously this is the oral cavity here, so the tongue would be here, this is the oral cavity. So then we sort of move into the pharynx at the posterior end here. So this of course would be the nasopharynx. And this is lined by that respiratory epithelium. Then we have this region here, which is known as the oropharynx. Now the oropharynx, because it actually is a sort of a mix between the pharynx and the oral cavity, and it has a potential for abrasion, doesn't have respiratory epithelium. It's actually lined by a stratified squamous epithelium. So it's a protective epithelium, and that'll be a non-keratinized type of epithelium. So the oropharynx is lined by that. If we sort of imagine this continuing down, we then would have the thyroid cartilage here. Whoops. So we have the thyroid cartilage here. We'd have the epiglottis here. And then we'd have our cricoid cartilage, and then we'd have our trachea starting to make its way down this way. So this is our larynx. And so the epiglottis, so this will become known as, and we're running out of room here, this is the laryngopharynx. And that's also lined by our respiratory epithelium. So those three regions of the pharynx are the nasopharynx, oropharynx, and laryngopharynx. The nasopharynx and the laryngopharynx are lined by respiratory epithelium. The oropharynx is lined by stratified squamous epithelium, so sort of a protective epithelium there. All right, so we then move into the respiratory tract. The epiglottis, of course, is this little flap of elastic cartilage, with a core of elastic cartilage, that superiorly has a lining of stratified squamous epithelium, and then inferiorly has a lining of the respiratory epithelium. Because if you imagine, what happens is when you swallow, your pharynx, whoa, pardon, I don't know what I did there. Let's get rid of that. So what happens is that when you swallow, your pharynx expands, and this actually causes the epiglottis to sort of close over. Now I've actually got I brought the anatomical model that you might have seen in practicals. So here's the model of the larynx and the early part of the trachea. So this bone up here, this is known as the hyoid bone. This is actually where our tongue muscles and things like that actually attach. It's a unique bone because it's actually the only bone that's not sort of making connection with any other bones. It sort of doesn't form those typical sort of joints. So it sort of floats there. But we've also got part of the rest of the larynx here. So we've got this big cartilage. This cartilage is known as the thyroid cartilage, and it's called the thyroid cartilage because the thyroid gland normally lies across here. So that's sort of in this region here. And it's got quite a prominent projection, so that in men who have less fat on their neck than me may have a projection here, and that's known as we typically know as the Adam's apple, but it's actually the thyroid cartilage. And so when you swallow, you can actually see that move up and down. And as I say, it tends to be larger in men, which is why we typically refer to it as the Adam's apple, and that's just the thyroid cartilage. We then have underneath that, we have the cricoid cartilage. Let's actually zoom back to our camera here. So this was what I was talking about, the hyoid bone. Then we have the thyroid cartilage. Then we have the cricoid cartilage, and then we actually have the trachea. So these are the rings of the trachea. Now, if we sort of flip it around, this is the epiglottis. So you can actually see this on a spring here. So when you swallow, that collapses down and covers the larynx, so that when you swallow, food is bypassed into the esophagus, which is posterior to this. And so the food comes down and then moves into the esophagus. And then we have these arytenoid cartilages, which you can see here. and they're actually attached to the vocal folds, which are our voice box. So I don't know how well you can see that, but these help us to begin to make sound. So they open and close. So when you breathe, they are abducted like that. So you breathe like that, and then when you talk, they close and they vibrate. So there's the little opening vibrates, and the opening is known as the rim glottis, and that rim glottis allows the air to escape, and it's actually the vibration of the air between these vocal folds which enables us to phonate, which is of course the other name for speaking. So that's what the larynx looks like, and those are the different components of it. As I said, this upper surface of the epiglottis is lined by a stratified squamous non-keratinized epithelium. The undersurface is lined by a respiratory epithelium. The rest of the tract is lined by a respiratory epithelium, except for the vocal folds. And because they have a potential when you talk to actually vibrate against each other, so when you breathe, they open up. When you talk, they vibrate between each other, and then they actually have a potential for abrasion. So they have a stratified squamous non-keratinized epithelium to provide a protective lining there. So the vocal folds have stratified squamous protective epithelium, whereas the rest is lined by respiratory epithelium. So then the air moves down to a respiratory tract from the larynx to the trachea. So we're going to move now to look at the trachea. Again, just going to sort of zoom out a little bit to put everyone into context. I'm just going to get rid of the annotations here. Okay, so what we're looking at here is a section of the esophagus, and here's the trachea. So this would be anterior, and this is posterior. So your esophagus is posterior to your trachea, and when you swallow, this expands, and you can see that the trachea is actually made up of these, well, you may not be able to see it right now, but it's made up of these C-shaped rings of hyaline cartilage. Okay, because it's C-shaped, it means that the posterior surface actually isn't enclosed by cartilage. It actually has smooth muscle. We can actually see that here. So this is the trachealis muscle, and this is found on the posterior surface. And one of the reasons for this is that it can contract and cause forceful expiration. But the other thing is, when the esophagus expands to accommodate you swallowing food and moves food down, this esophagus can expand, and it doesn't press against the hard cartilage of the hyaline cartilage of the trachea. So we can actually see, I'm going to go back to my pen here, the different regions of the trachea. What happens when you lose your voice from talking too much? That's a good question. Let me think. I imagine that what happens is that you actually get inflammation of those vocal folds, and that they don't vibrate against each other as well as they did previously, because they sort of swell up, and therefore there's not the typical sort of space between them. And so it's a little bit like, when you breathe, there's sort of a larger opening, and so because there's sort of less vibration taking place because the vocal folds are thicker, then you're actually probably getting much, a hoarser voice. You eventually lose your voice because your vocal folds aren't vibrating completely like they were previously. Again, I think it's related to inflammation of the mucosa that lines the surface of those vocal folds, but I might need to double check on that, and I'll post something in the discussion forum if I'm wrong, okay, if you don't mind, Gamer Ethan. So the trachea here, as I mentioned, is lined by this C-shaped hyaline cartilage. So here's our hyaline cartilage, or our cartilaginous layer. Here we have the respiratory epithelium. So this is our respiratory epithelium lining our trachea. Will this also be the case in laryngitis? Yeah, anything with itis in the end of the name means inflammation of. So laryngitis is inflammation of the larynx, which basically means the vocal folds in that region. So again, yeah, you can have inflammation brings about increased secretion of mucus, and therefore you can have a thickening because of the mucus, but also you get inflammation, edema in that area as well. You know, when you get an infection, you get inflammation. One of the things that happens is that the tissue becomes red, it becomes hot, and there's swelling associated with blood vessels sort of leaking in that area. And so that's often what happens within those areas as well. So these are the respiratory epithelium. We can sort of zoom in and have a look at that. So here's our respiratory epithelium. You can see the little hairs of the cilia. Now, interspersed between these, and they're not that easy to see, but they are present, are goblet cells. And the goblet cells are producing mucus, and the mucus is coming onto the surface here and performing one of the functions of the filtering that was asked about before. Once we get past the nasal cavity, once we get past the nasal hairs, we then move into the lower respiratory tract, and the filtering is brought about by the mucus that's being secreted onto the surface. All right, nothing like technical issues in your live stream to keep you on your toes. All right, so we were talking about the respiratory epithelium. As you remember, it's a pseudostratified ciliated columna. With goblet cells. Now, unfortunately in this section, the goblet cells aren't very easy to distinguish, but we can certainly see the cilia here, the little hair-like structures on the surface. And together, the cilia and the goblet cells form what's known as a mucociliary escalator. Now that's probably the worst escalator in the world to actually ride. I can't imagine holding on to the handrails. You probably need lots of alcohol wipe after that. So the mucociliary escalator is a concept where the goblet cells plus any seromucous glands which exist within the submucosa secrete onto the surface any particles which have actually bypassed the nasal hairs, the respiratory system in the nasal cavity, the nasopharynx, the laryngopharynx, and then actually got into the trachea, can actually get trapped within the mucus being produced here. Now the cilia create a current, and that moves that mucus and its trapped particles up into the mouth. Now you remember that I just mentioned about the larynx and those vocal folds actually having stratified squamous. There's no cilia to move it. But every now and then you might notice that you might go, yeah, I'm sorry, I can't do much about the buffering from my end. I don't know if anyone else is having the same problem. Maybe you might need to refresh the stream and that might help the buffering problem. So does that mean, I don't understand what client side means. Does that mean it's my side? Not your side, Jamie. Okay, thank you. No, that's fine. Thank you very much. All right, okay. So the mucociliary escalator. So it brings up the trapped mucus, the trapped particles within the mucus, and and that helps to move that mucus up into the oral cavity where it's eventually swallowed, and stomach acid gets rid of those particles. It's kind of gross to think about, but it's really important for the keeping the air filtered as we move down. He's not saying it's your fault, he's just saying that whatever issues are actually happening on your end. It's not an issue with the stream. I'm sorry about that, Chanel. As I say, often refreshing the stream can actually help. Sort of like it's like a clean start to the stream. All right, so this is the pseudostratified ciliated columna. sort of might zoom out a little bit now. So sometimes we can actually find glands in this region. Here we have the cartilage, so the hyaline cartilage, and then we have an adventitia which sort of binds it to the surrounding structures. So as I mentioned, on the posterior surface here, if we sort of think about this structure here, we've got our cartilage running around this way, forming this C-shaped structure, and then the posterior part of it is actually formed by this smooth muscle layer, which is the trachealis muscle. Okay. All right, does anyone have any questions about that? I think that was just a quick overview of the structure of the trachea. Of course, the C-shaped cartilage rings sort of act a little bit like, you know, the rings on a vacuum hose. So you know that sort of bends, but it doesn't actually close. So it actually, the hyaline cartilage offers a flexibility, but also it's quite a sturdy structure, so it keeps the airways open. All right. We then move from the trachea. Now I've got another model here, so we'll go back to the camera. So we've got here, we've got our model, we've got our larynx here. So here's our thyroid cartilage. You can actually see the thyroid gland here. So they sort of left it on this model. Then we have the cricoid cartilage, and then we have it into the trachea, and then we begin to actually move in towards the lower part of the respiratory tract here. So these are, of course, the first branches of the trachea, and these are, of course, known as primary bronchi. So there's two primary bronchi. Now, who remembers the name of this junction between the two primary bronchi, or the end of the trachea, if you like? Who remembers what that's called? Yes, Chanel, well done. Yes, it's called the carina. So that's the carina. Then we have our two primary bronchi. Those two primary bronchi are the sort of last parts that are outside of the lung. Once we then move into this region, these are the secondary bronchi, and these are actually within the substance of the lung itself. So the lungs will be sort of sitting here, if you like, and here. And so you can actually see those branches there. So each of the secondary bronchi are often referred to as lobar branches because each of them supplies the lobes of the lung. And on the left, we have two lobes, and on the right we have three, because of course on the left-hand side we actually have the heart. So we have that cardiac notch. And so we only have the two lobes. We have the superior and the inferior lobe. Whereas on the right-hand side, we have the superior lobe, the middle lobe, and then the inferior lobe. So each of these is a secondary bronchus, which are sometimes referred to as lobar branches or lobar bronchi because they supply lobe. Then they branch into tertiary branches, which are often referred to as bronchopulmonary segments. Each of these has a separate branch, and there's about 10 bronchopulmonary segments per lung, and you can see them sort of color coded in this model here. Okay, so then we begin to move down the respiratory tract. We can sort of zoom past here, and so here we are in the lung. That's good you can't see it because it was a really awful drawing. So I apologize for that. I forgot to click the button. Thanks for letting me know. All right, so what I drew in really, really terrible form was an attempt at drawing the lungs and the various branches and so on. So I'm never going to win any awards for anatomy drawing. So we've got the thoracic wall, got the diaphragm here. Thanks very much. So we have the lining here of the pleura, lines here, and then it comes in and lines the surface of the lung. Okay, and so this space is the pleural space. So then this layer here, this is known as the parietal pleura. And then the pleural layer that's attached to the surface of the lung is known as the visceral pleura. And there's fluid within here, and we know that there's a partial pressure within this region as well, and that they actually quite closely adhered, so that when you inhale, your chest expands, and that connection between the two pleura actually helps to pull the lungs out and inflate the lungs, increasing the volume and therefore decreasing the pressure, causing the atmospheric pressure to move into the lungs and therefore cause inhalation to take place. So the pleura sits on the surface. Likusha, thank you very much for the follow. Great to have you along on the channel. So what we're looking at here is the histological section of the lung. Out here on the surface, this is where we're actually going to find our visceral pleura. Now, it's been sort of disrupted on this side. It looks like there might be a little bit on this side here. Let me just get rid of that there. So if I want to go to the outer surface here, it doesn't look like it's there, but I certainly know it's on this side. We wait for it to catch up. So here we have the connective tissue, and then you might be able to see these sort of flattened nuclei. Can you see these here? I'll just zoom in a little bit. These are the simple squamous epithelial lining of the visceral pleura. So that sits on the outside of the lungs. So there's the simple squamous cells on the surface there. In the tube, I was told that the 300 million alveoli in lungs as a whole, but the YouTube video provided in the pre-class says that there's 700 million. Somewhere between 300 and 700 alveoli. Look, I don't know the exact numbers. I don't think really the exact number is going to be super important, but there are a lot of alveoli, which means that there's a lot of surface area for gas exchange. It's sort of a roughly equivalent if you were to sort of spread it out over space. It's just slightly smaller than a tennis court in terms of surface area for each lung. So it's quite a large surface area. Yes, your lungs won't be very good with smoking. All right, so let's clear this, close this. All right, so when we actually have a look at the structure of the lungs, we can actually see some of these features. So here's some of the bronchus. Here. Now, remember when we were looking at the trachea had those nice C-shaped cartilage rings. In here we now actually see that the cartilage, rather than being rings, are actually these sort of more plate-like structures. And then this is actually a bronchus within the substance of the lung. Then all of these holes out here, these are actually the alveoli. Okay, so the air is conducted still by the bronchus. These are actually seromucous glands. The thing that we actually can see now is sort of a new layer here. Can you see this very pink tissue here? This is actually smooth muscle now. No worries. Thanks very much. Have a good night. This is smooth muscle. This layer, remember, the smooth muscle in the trachea was only on that posterior surface in the form of the trachealis muscle. Here, it's actually become a more prominent layer. And this is part of the issue when someone actually has asthma, is that something like this, for example, if we sort of zoom in over here, there's no cartilage on this side, but there is smooth muscle. And if this smooth muscle undergoes bronchoconstriction, then you can actually reduce the size of the airways and therefore increase resistance and cause issues about getting the air down to the lower airways. So you can see here there's no cartilage present in this region. So the cartilage plates reduce in number to get to about the level of the bronchiole, and then there's no more cartilage present at all. We can see that the epithelium also changes in this region as well. We lose our goblet cells. They no longer become present because we don't want mucus going down to the area where gas exchange is going to occur. So we want to keep that membrane, that respiratory membrane, as thin as we possibly can. So we're keeping our glands reduced, and we're just now moving into these smaller conducting portions. So you can actually see here, can you see the sort of branching? So this is one of the respiratory ducts, respiratory bronchioles. We can actually see these little openings into alveoli in the wall here, and then we're opening into the alveolar ducts, and then this is opening into the alveolar sac, and then we've got a number of these alveoli branching off this alveolar sac, and same on this side as well. So the air is coming down this way, and then it's going to go this way and this way. So this is the respiratory bronchiole, and this is the alveolar duct, and then this is the alveolar sac. Each of these is an alveolar sac, and each of these is an alveolus, which is a little sort of branch here. So what if someone has a chest infection? So what happens is mucus continues to, and we know that infection brings about an increase in synthesis of mucus, and it does make it difficult for a person to keep getting rid of that mucus if they're producing lots and lots of mucus. And so they cough a lot to actually help move that mucus out from the lower parts of their lungs. Now this is why people who smoke actually have a cough, because the cilia are actually killed by smoke, cigarette smoke. There's toxins within there that kill the cilia. We lose that mucociliary escalator, and therefore the person's mucus actually collects in the lower parts of the respiratory tract, causing them to need to cough to actually get rid of that mucus from their lower respiratory tract. With infection, you're getting lots of mucus, therefore it's a lot of work for that mucociliary escalator to actually get rid of that mucus, and so people cough to have to keep continually getting rid of that mucus. Cystic fibrosis is a condition that brings about excess production of mucus within the respiratory tract, and they need a lot of help to actually get rid of the mucus in their lungs as well. And unfortunately for sufferers of cystic fibrosis, one of the causes of their illness is chest infections, repeated chest infection, and it usually lands them in hospital, and it sometimes causes their death. Okay, I'm sorry about that. I don't know how much of that you saw. I was talking about chest infections and how it produces an excess of mucus, and it yeah. So Sam, unfortunately, I'm gonna leave that more to our next stream. I'm going to be focusing on the anatomy a little bit more today than I am about the physiology. When we have James here, we can talk more about obstructive and restrictive conditions, and I'll certainly make a note of that to talk about next time. Sorry, I can talk about emphysema, but I'm not exactly sure about the restrictive conditions. So we can have James come and talk to us about that if you don't mind. We'll get there. Yeah, okay. Yeah, I'm sorry about that. So let me just make sure I write that down. Okay, so come back here. We zoom in, we can actually see the alveoli. The alveoli are made up of two main cell types, type 1 alveolar cells and type 2 alveolar cells. Now the type 2 alveolar cells, interestingly, are actually the most numerous within the lungs, within the alveoli, but they have the least amount of surface area. So type 1 pneumocytes, despite being the most of the surface area, they're actually less numerous than the type 2 alveolar cells. So we, of course, moving down now towards the the area of gas exchange. So we're moving towards the respiratory membrane. So if we think about an alveolus sort of being circular in shape, we can have our type 2 pneumocytes, and then we can have our type 1 alveolar cells. And the type 1 alveolar cells actually have tight junctions between them, and they're really important. Okay, so here might be our type 2 pneumocyte. They actually are responsible for the secretion of surfactant. Type 2 alveolar cells, sometimes they're known as pneumocytes. I don't know if you've seen that terminology before. And then we've got our type 1 here. So these release surfactant, and surfactant is important to decrease surface tension. Now what that means is, when you exhale and the air is actually sort of contracted, we get this sort of natural recoil of elastin within the alveolar walls. The surfaces of the epithelium can actually come into contact. Now, if you've got a layer of surfactant, what that does is it actually decreases the surface tension so that they're not sticky. But if you don't have the surfactant, what happens is those membranes stick together so that the next time you inhale, it actually causes a lot more effort to actually open up those airways. And this is sort of in the bronchiole level downwards, so the alveolar sac, the ducts, and the alveoli themselves. So the surfactant is released to reduce surface tension so that the membranes don't stick together, and therefore it takes a lot more effort to actually open up the airways in the next inhalation. So the blood vessels, of course, the capillaries are on the outside here. So they're also lined by a simple squamous lining, endothelial lining. And so here, this is sort of where we have our respiratory membrane here. And I'm going to show you a really easy way to remember to draw this. It's basically lines, just simple lines. So if we were to sort of zoom in and have a look at the structure of this, let's start with the capillary level. So if we sort of start here, we've got our capillary. So here's our endothelial cell. Okay, so this is, let's imagine we've got our red blood cell here, so that we know we're in the capillary. So this is our simple squamous endothelium, so very, very thin. Now each epithelium we know has a basal lamina. Now the type 1 alveolar cell also has a basal lamina, so we actually have a mix, a sort of a fusion between the two basal laminas. So we have a fused basal lamina, or is sometimes referred to just as a basement membrane, even though it's not really a basement membrane if we think about the normal structure. And then we have a very thin layer of the type 1 alveolar cell. Which is also, of course, a simple squamous epithelial cell. Okay, and then, you know, if we were to sort of think about the actual structure of it, we might sort of imagine that there's a little layer of surfactant on the surface here that's helping to prevent that adhesion. So these are the layers which actually make up our respiratory membrane. So basically, if you get asked in an exam to actually illustrate the structure of the respiratory membrane, you just draw lines, and they say this is the simple squamous endothelial lining, this is the fused basal lamina or the fused basement membrane, this is the type 1 alveolar cell, and so here we have gas exchange occurring. We're getting CO2 exchanged, and we're getting oxygen, sorry, the wrong way around. So we're getting oxygen picked up by the blood, and we're getting carbon dioxide exchanged into the lungs for exhalation. So we want this membrane to be as thin as possible, because we don't want to really interfere with that gas exchange or that diffusion. So anything that sort of thickens the diffusion membrane, or the diffusion barrier, I suppose, then potentially can interfere with diffusion. And we know that's one of the important areas of gas exchange that the anatomy can play a role in. As I mentioned, if you have excess mucus and it accumulates here, it's going to accumulate, of course, within the alveolus, then you're potentially interfering with that diffusion that's taking place within that region. All right, well, that's about it for the anatomy of the respiratory system. As I mentioned, we'll definitely cover the physiology and move into talking about Dalton's laws, Boyle's laws, Henry's laws in the next stream. Is there any sort of final questions or anything about the respiratory membrane that you want to ask about while I'm here? Any of the anatomy that we've just talked about? Just about elasticity. Okay, so what intermolecular process primarily drives the formation of a biolayer when phospholipids are added to water? Okay, so that's related to the amphipathicity of the biophosphate lipids. We have the phospholipids. It has a water-loving end and a water-hating end here, and so that when you throw them into water, the two hydrophobic regions form together, and we have our hydrophilic, and this is also hydrophilic, actually interacting with the extracellular water and the intracellular water, so it forms a natural lipid bilayer. Hopefully that answered your question. I think that question was there to try to stump me. Was related to the fact, amphipathic means that it has a hydrophobic and hydrophilic region. Elasticity, so actually I've got a nice slide here. Yeah. So this is actually a section of the lung chenelle that's actually been stained with a special stain called Aucian. Aucian is specific for elastic fibers. So we can actually sort of zoom in here, and wherever you see this sort of brown material, you can actually, these are actually elastic fibers. So they're found in the interalveolar walls. And what happens is with emphysema, for example, it actually stimulates neutrophils to release the enzyme elastase. Now, elastase begins the breakdown of these elastic fibers, which eventually breaks down these interalveolar walls, so that you've actually lose all of this surface area, and it causes what's called sort of like a honeycomb type of appearance to the lung structure. No worries, mate. So if you can imagine, what happens is with the breakdown of these interalveolar septa between the adjacent alveoli here, the breakdown of the elastin causes the breakdown of the wall of the interalveolar septa, means that you lose all of this area for surface area for gas exchange. So you're left with just the outer alveoli, and it forms what's called a honeycomb type of lung. We get less elasticity, so we get less able to stretch and naturally recoil, but we also lose surface area for gas exchange. So we actually have less surface area for gas exchange, and therefore the person has a lot of problems actually getting enough oxygen. And so obviously someone with emphysema, which is a progressive condition, typically end up on oxygen to actually survive. Does that sort of make sense about elasticity? Yeah, absolutely. So you're losing sort of the elasticity of the lungs, but you're also losing that surface area, which is a really important thing. And as I say, it's often related to overstimulation of neutrophils, which are found within this area, and they release the enzyme elastase, which breaks down the elastin, which breaks down the walls of the alveoli, so you get this sort of big honeycomb-like appearance. All right, well, unless there's any other questions, I think we might leave it there. I really appreciate you coming along. I know it wasn't exactly perhaps what you had hoped in terms of getting some early physiology, but I promise we will come back to it in the next stream after the mid-semester break when James is feeling a little bit better. So we might leave the stream there. I will see you on Milo. Don't forget, if you've got questions, please post them on Milo in the discussion forum there, or you can actually tweet them to me if you're not a UTAS student. Come along and ask questions. Does a reduction in the elasticity reduce inspiration? In a sense, I suppose, if we think about lung compliance being related to elasticity, if you don't have very elastic chest wall and the lungs, therefore inspiration may be affected, therefore pressures aren't going to be as great, and you may have trouble ventilating, getting enough of the air down into the alveoli. But the elasticity, if you remember, is really important for exhalation, getting rid of that air. So you may potentially end up with more carbon dioxide remaining behind, dead space within the lungs as well. Smaller area means less pressure. Yeah, so that goes back to Boyle's law. In a closed system, the larger the volume, the smaller the pressure, and so on. Yeah, so that's Boyle's law that Chanel's talking about there. Potentially the loss of inspiration is one, being able to expand the lungs, but then it's also the natural recoil that's lost as well. So it's probably a mix. But again, we will come back to those ideas about compliance and restrictive conditions and so on. So anyway, thanks very much for coming along. I really appreciate you putting up with my awful drawings and my histology slides and focusing on the anatomy. As I say, we will come back to the physiology more in our future streams. So for those UTAS students, enjoy your mid-semester break next time. Thanks everyone for coming along. I apologise for the issues with the stream. Sometimes the university web isn't always that reliable. Thanks Boston Monday, thanks Chanel, thanks Lorquado, thanks Sam. I appreciate you hanging out and coming along and seeing this. Yeah, we will be back after the mid-semester break, and we'll be able to answer your questions there. So have a good night, have a good semester break, and we'll see you in the next stream.